again thank the organising committee for the invitation to the city beautiful Chandigarh. I had the opportunity to visit some of the local sites and absolutely incredible. This is a very, very special city and I feel very honoured to be here. I learned a lot about local culture last night. I even learned some dance moves from the committee as well. So thank you once again. Yesterday, when we talked about wounds, we talked about the big wounds, we talked about the small wounds and the puncture wounds. And now I want to extend that further and I want to talk to you about the challenges, particularly of severe distal limb trauma and distal limb injuries. Because these are something, at least in Australia, we see very commonly, mainly due to road traffic accidents. And I believe this is something that is probably very common also in your animal population. So what makes these more challenging? Well, we touched on this yesterday. In the distal limb, we have a sparsity of tissue. That tissue is under tension. There's not a whole lot of muscle that surrounds the limb at this level. So bone, ligament and tendon involvement is also very common. So when I see a wound like this, again, it can be a little bit overwhelming to start with. But remembering the body knows what it wants to do and we need to know our role as veterinary surgeons. Our role is to support the body through this healing process. However, if we don't give it some assistance, it's unlikely this is going to heal on its own. So what are we going to do? Well, remembering we're that support crew, we're the pit crew. We need to understand what the body is trying to do through each stage of healing and work through that process. And so again, a very important fact that we spoke about yesterday is you cannot speed up the wound healing process, but you can definitely slow that process down by making the incorrect decisions at each step. We mentioned yesterday that assessment of this is really important, and it's never more important than in the distal limb because we know the vital structures of the foot are essential to locomotion. And when I think about what gives animals quality of life, then I think one of those is definitely mobility and pain-free mobility. So when I see a wound like this, again, we're asking ourselves what tissues are involved and what stage of healing are we at? We've got radiographs that can help us assess that. And I want to take you through a quick example here. This is a very cute dog, Banner. We have a very busy emergency department at the hospital that I work at. He was hit by a car. He's otherwise healthy. I was told the following morning this dog had a small wound on its right hind limb, but there were no fractures that were evident. So the emergency department were ready to discharge this dog with a small wound and we would expect uneventful healing. But Ellie talked yesterday about the importance of watching your animal walk around because this tells you a lot of information. An animal with a single limb injury should be strongly ambulatory but holding one leg up. If that injury is small, it should be walking on all four limbs. When I asked to look at the radiographs, this is what we could see. Take a look, see if you can see any fractures. So when I watched Banner walk, I said, let me just have a quick look at this dog before we send him home. And here he is. Okay. So if this dog just has a small graze on its limb, you would ask yourself, would you be expecting the dog to walk in this way? And my answer would be no. If it was just a skin wound, I'd expect the animal to be weight-bearing fully on that limb. So what do we do now? We take off the bandage and we have a look, and this is what we're faced with. It's a relatively small wound here. It's not particularly big, but we've got an animal that isn't weight-bearing at all. And if an animal isn't putting any weight on that limb, then we're much more concerned about orthopedic injury. So when you look at this radiograph, any comments about this and what you're seeing? This is what we had. So the first thing I would say is that this is inadequate to take a single X-ray. We know about the importance of two views, and it's never more important than when you're dealing with the distal limb. You need well-positioned radiographs. And what we have here is a single radiograph that's oblique. So I don't think you can make a full assessment when you have a radiograph like this. I don't think we can truly say there's no orthopedic injury. When we explore, then if we simply pull that skin down, what we can see is bone. This immediately tells us there is bony involvement, and this is really common with distal limb injury because often the wound does not directly overlay the major site of injury. And this is because when an animal is dragged along the road, often that skin is pulled to a new location. And so be very, very careful when assessing these wounds because the penetration doesn't go straight into the limb. The skin is pulled along and the injury is often distant to that skin wound. So by simply pulling that skin down, we can learn an awful lot. This has bony involvement. What do we do next if we want to assess bones? We're going to take some radiographs. And in this case here, when we have correctly positioned radiographs, you can all see very clearly now what we have is a malleolar fracture. Here's my pointer, just down here. When you see we take stress radiographs, you can see when we apply a lateral or medial force here, there's nothing. A lateral force, it opens up. So again, we can learn an awful lot with simple radiographs. Well-positioned radiographs will show you the site of pathology. Stressed or dynamic radiographs can show you how things are moving. So there's a lot we can learn from this. And so in this case, this is a really good example of how a missed injury yet could easily occur in an emergency setting. So distal limb injuries have a few tricks. First one is how that skin is related to the underlying injury. Palpate these dogs carefully because we know that hyperextension injuries are common, ligamentous injuries are common that result in carpal hyperextension, but also tarsometatarsal luxations. Now often these are not apparent on plain radiographs, and so you need to palpate the limb and take the appropriate radiographs if you palpate any instability. So the visual inspection, remembering there may be a flap of skin that covers the site of pathology, the skin may have moved. Palpate for instability. If it's a single limb, compare it to the other side. Cats are notorious for having increased ranges of motion, so you don't want to overinterpret it. Dogs like Bernese mountain dogs, Newfoundlands, these dogs have very loose joints, and so you want to compare it to the other side. Remembering that you also need to palpate in every position of that joint. So in full extension, in neutral position, and in flexion, you're feeling for instability because sometimes we only see partial damage to those collateral ligaments or other ligaments. And then well-positioned radiographs. So if you take a single oblique conscious radiograph, that won't give you the information. Two orthogonal views, and if you have it available to you, CTs are what I would recommend in the distal limb, carpus and tarsus, because of the problem of superimposition. You cannot identify each bone in isolation in those particular anatomical locations. So CT scans are ideal in these situations. I want you to note here, again, look at this flap of skin. When we see distal limb injuries, often you have one edge which has been lifted off and one edge which is stuck down. You need to often find that and lift it up, and this will reveal the true extent of the injury. So here we can see that flap in this position here. Remembering what we're doing at that first stage of healing, we're right at this point here where we want to help with coagulation, some gentle pressure, and avoid additional contamination. So what we're going to do is to place a light sterile dressing on this, and then we're going to Ellie and we're going to ask her to stabilize the patient for us. Here again, we can see another example. If you see this center image here, we can see the edge on the left side is the edge that has been rolled back. The other edge is stuck down fast. And so this doesn't look too bad. This is the same dog here, the image now on our right. And you'll see what we've done, sterile gloves, and we're lifting that flap back, and that reveals the true extent of this injury. We're actually going to follow this dog through now to see how we treat it. There is nothing different when it comes to supporting the soft tissue structures here. It's just like we talked about yesterday. Surgical debridement of this, sharp debridement, conservative and staged. But you need to generally anaesthetize these patients to assess the full extent of these injuries. Remembering we said initially, sterile lavage, That can be tap water. It's not about the solution you put in the fluids, it's about the volume of fluid. So clean tap water is appropriate, ideally sterile saline, but if that's not available, large volumes of tap water are appropriate. You want to decontaminate this. You want to help the body remove every bit of foreign material, every bit of necrotic tissue, and every bit of bacteria that you can remove is ideal. We mentioned yesterday the dressings that we need in the debridement phase. You have two choices. I think you could happily put a wet to dry dressing on this. That's non-selective debridement, but this is a heavily contaminated wound. Remembering that's a sterile swab, sterile saline, wrung out and placed onto the wound. When it dries out in 24 hours, it'll be painful to remove, but it's going to remove a lot of necrotic tissue and contaminants. The alternative to this, as we mentioned yesterday, is the moisture retentive dressings, the foams, which are highly absorptive and allow the body to selectively debride. That's autolytic debridement. This is day 2. What we can see at this stage is we're doing a continual reassessment. At this stage here, we've removed everything that's obviously dead, but what you can see here is the severe bone involvement. And what I've got here in this digit here is essentially half of the bone has been abraded away. And so if we have significant injury or loss of bone, then we may decide amputation of that digit is favourable to reconstruction. So if you have lost more than about 20% of that bone width, then I would generally look at amputation as the fastest step to resolution compared to trying to repair that joint. This is in terms of digits only. So again, daily bandage changes, selective debridement. At 4 days, our debridement now includes that lateral digit, so we've taken away the toe, and we've also partially closed this wound. So this is delayed primary closure. We know that this has had a chance to decontaminate, so now we've partially closed that wound, and we're going to ask ourselves, is this moving in the direction that we want it to see? In other words, are we starting to see granulation tissue, or are we stuck in the debridement phase? Because if we're stuck in the debridement phase, again, this is when I'm going to get a sample for wound culture, about day 4, further debridement, and I'm looking for a factor that means I'm not moving from the debridement phase to the repair phase. And I know this is a little repetitive from yesterday, but I just want to make sure that we are firm on those principles of wound management because they don't change. The tissues respond the same. Now at day 6 here, we can see we've got lots of granulation tissue starting to form in this wound. This is a really good thing. This is day 8. We said about day 8 here, when you've got a healthy granulation tissue bed, dressing changes probably can be once a week. The less you disturb that wound environment, the faster the healing process. Every time you take that off, top layer is going to dry out, you're going to lose some cells. So generally now I'm looking at about 1 week apart. So here we go again. Slight concern if you take this off and you're not used to a moisture retentive dressing, looks infected. Looks like a sticky purulent exudate. But this is in fact the secret to the success because this is maintaining moisture and allowing new skin to form underneath this bandage. You can see here just around the edges we're getting reepithelialization and we're also getting further granulation tissue forming. Here we see 17 and 24 days. Again, once a week changes. But what I want you to note from this point here, and this is one of the differences to large trunk wounds, if you had a 1 centimetre gap on the thorax, you'd be expecting that to heal within probably 1 to 2 weeks. In the distal limb here, remembering that the myofibroblast will allow these edges to contract and come in, but they will only stop once we get contact inhibition, i.e. the wound heals, or the tension in the wound equals a tension in the surrounding skin. So in the limb, because there's a lot of tension in that skin, you don't get a lot of contraction. So the only way this is going to heal is by new skin growing across that granulation tissue bed. And this is a slow process. And so when I show you here how long that took, another 2 months to come that final distance. And that's the difference between trunk wounds and distal limb injuries. So I'm going to show you some alternate techniques to speed that process up because we can't rely upon contraction in these distal limb wounds. So here's another case here, Debridement may include bone as well. Granulation tissue formation. We can see this is a really nice granulation tissue bed. This is the aim of where we want to get to from the initial presentation. So this is good. But again, the process for this then to allow new skin to grow over is a very slow one. It also can mean that the skin at the end of this is very thin and could potentially be prone to further damage. So one of the things I wanted to talk about in this lecture in particular is how we might use skin grafts. Because the nice thing about the distal limb is that you can bandage this quite conveniently, and there's not a lot of movement apart from over the joints. So these are ideal for skin grafting. So could I have a show of hands here? Who's performed a skin graft before? Okay, so not so many, but the skin graft is something that I wouldn't be particularly afraid of. The way I think of a skin graft is very different to a vascularized flap. So whenever you take a piece of skin, create a tongue of tissue and rotate it over the wound, this is vascularized. And the thing that everyone is concerned about is all of a sudden we lose the blood supply to the flap and we lose the flap. And that's devastating when it happens. Skin grafts are different. Skin grafts are essentially a free transfer of skin. It's essentially dead skin that you're taking away, and you're sticking it onto a healthy granulation tissue bed. And we're waiting for that skin to come alive again and come alive through a new blood supply which comes from the wound bed. So generally speaking, the donor site where you take the skin is completely closed, and so you don't have a lot to lose here. And I'll talk you through how I'll go through skin grafts, but then also give you some ideas of how you might try it. I guess dip your toe in the water, so to speak, how you might try this without feeling as though you're going to cause this animal any further harm. So these free grafts, again, dead skin transplanted onto the bed. It has no blood supply at this stage. So there are 4 key steps that are required before that skin comes alive. We need adhesion, first of all. So you don't want to be changing bandages all the time, because any movement will stop that adhesing to that granulation tissue bed. So we need adhesion. Then we need survival through something called plasmatic imbibition. So that graft imbibes, or it draws up wound fluid from that granulation tissue bed to stay alive. This means the graft must be thin. If the graft is too thick, it will not absorb the nutrients from that wound bed, and the skin will continue to die. So the clock is ticking once you take that graft, because that skin, those cells in that skin, need some energy to come back alive. And so this is the process of plasmatic imbibition, so thin graft. Then we have inosculation. So this is new blood vessels growing in. Now the key here to get new vessels growing up is to place it on a very healthy vascular bed. If you place a graft over bone or tendon, any dense connective tissue, there's less chance of new blood vessels growing into it. So you want a nice healthy bed, and granulation tissue is perfect. So healthy granulation tissue bed is what I'm looking for. And then the final step is vascular ingrowth. Takes about 3 weeks for this to fully occur. So although you can put a graft on a fresh tissue bed, and in these cases this is due to tumour excision, although it's been reported that you can place a graft directly onto muscle, my recommendation, if you haven't done this before, is manage it as an open wound until you get a healthy granulation tissue bed. Once you have that, then I would do my graft. That's going to give you a better chance of graft take. There are split thickness grafts, but you need a special machine called a dermatome to take that split thickness graft. Generally in veterinary practice, we will take a full thickness graft. So we'll take all of the skin. Now, I tend to elevate the graft as I take it off the body wall of the animal. I generally use a lateral thorax. But you can cut out a piece of skin, close that up, and then take it away and prepare it. And by preparing it, what we're talking about is removing all of the fat. And the fat acts as a barrier that stops that imbibition. So you want to remove all of the fat. I tend not to scrape, but what I tend to use is sharp dissection here to remove all that fat. and then we mesh it. And meshing, I think, is very important, because the better that you mesh it, the better it sits on that wound bed. So remembering, on the limb, it's not a flat surface. So your graft has to contour to the shape of the limb. If you mesh it, it will better sit down in contact with the bed, and that will give you a better chance of adhesion and then imbibition, and therefore graft survival. So I would always mesh it. The other advantage of meshing is it allows any wound fluid to leak out through those holes. Because if you take a full thickness unmeshed graft and place it on, if you get any fluid that lifts it up, then again that graft will die. So the meshing has a number of purposes. It means probably not as an acceptable cosmetic result for the patient, because you may have hairless areas where you've cut those holes, but it will give you a much better chance for take. So I would always go full thickness, cut away the fat, and mesh them. When it comes to placing that graft onto the bed, there's a few different ways to do that. Some people like to onlay it and have it overlapping the edges, accepting that the edges of that skin graft will die away. That's acceptable. The other option is you cut it perfectly to size and you tack it around the edges. Some people like to put sutures in the middle of the graft. I generally don't, because it's meshed and it will just sit quite nicely, and I'm going to also bandage on top of it. This is probably one of the few times I like to use Gelinet, and so Gelinet is that petroleum impregnated gauze, and that works very nicely because as I remove it, it doesn't stick to the graft. Rarely do I put antibiotic ointment on wounds, because generally speaking, the antibiotic ointments are more cytotoxic than a benefit. But in these cases here, I've got a piece of skin which has no blood supply, which means it has no host defenses. And so these are one of the rare cases where I will use an antibiotic ointment directly on that graft, because if we have infection, remembering this is devascularized skin, if we get an infection, that will mean graft failure. One of the new and exciting things that we're seeing is the reporting of the use of negative pressure wound therapy. So this is where we create a seal around that wound, and we actually use a machine to suck away all the air out and to create negative pressure within that wound. And we know that skin grafts take better using this technique than without. However, you've got to have the setup, and the animal has to be attached to tubing essentially for that process. So it's not always practical. Many of the times the reality is we see partial take, so some of that skin survives, but some of it may die away. And we can see here, this is what it can look like in the early days, often the first change. About day 5 to 7 is when I'll do the first bandage change. And here we can see again a couple of examples where we've had partial take, and this is perfectly acceptable, because what that will do is again decrease that healing time by probably several weeks. So these are both positive results. But the things that we're trying to avoid are motion. So again, we bandage these. Lifting of the graft. So again, the bandage will help. Telling the owners not to allow the dog to run around. And then we want to reduce the risk of infection. Now, if you don't feel comfortable going straight to that full thickness skin graft, I'd recommend you try seed grafting. This was a paper published by a colleague of mine, and he reported a number of cases where they use very simple instrumentation, a skin biopsy punch. And what you do is you take multiple skin biopsies. You then trim the fat off them, and you can either make a little slit, or you can use a biopsy punch of a smaller size to make a little deficit in the granulation tissue, and then pop that graft in there. And so in this way, all you've got to lose are maybe 10 little biopsy punch sites, all with single sutures. And you can do them in different areas of the dog, but generally lateral thorax. But you can see how this can speed up that healing process by creating greater edges, greater distance of the edges from which new skin can grow. So if you don't feel comfortable doing a full thickness skin graft, then I would definitely try seed grafts. Not a lot to lose here, but your patients may benefit greatly. All right, we're halfway through. Mental break now. I'm taking you to the southernmost part of Australia. This is Wineglass Bay in Tasmania. I don't know if anyone has been there. It's like going back in time about 20 years. Everyone is really friendly and the environment is pristine and beautiful. It's known for great wildlife. This is the platypus. So they're very elusive. Rarely do they come out. And does everyone know this animal? This is a Tasmanian devil. Don't pat one of these things. It will remove your hand in an instant. They're very violent. So, known for wonderful wildlife. And again, that question that you always ask, is there a big version? Yes, there is. Again, we have the big platypus and the big Tassie devil. So you're probably thinking Australians are all insane because everything has to be big. I don't know why. I was thinking about it last night. I don't even know where this came from, but anyway, we love big things. Okay, let's get back into it. So now I want to talk to you about other injuries that occur in the distal limb. So we talked about soft tissue, it's skin. We talked about that yesterday. Not a lot of differences there. So I'm losing a bit of my screen here. It's not just too much drinking from last night, I think. All right, so what do we want to do? We want to identify if we've got any damage to the bones or the ligaments or tendons. So the first thing you can do is to palpate that limb. We spoke of that already. We talked about radiographs, well-positioned radiographs, stressed radiographs to highlight any instability. So you don't see ligaments and tendons when you do a radiograph, but you can see the inadvertent effects of damage because the range of motion increases. And then ideally, with the distal limb, we would use a CT scan because of the complex anatomy. And often people go, oh, this is, CT scans are, they're just what's in the really big hospitals. But technology changes so rapidly that I have no doubt that CT will replace radiographs in many situations here and become much more readily available. So if I've got instability that I can palpate, in this case, it's a tarsocrural instability. I can't let that limb remain unstable because that will also impair the healing soft tissues because movement is something that will delay that healing process. And so I like to use a transarticular external skeletal fixator here. In this way, it's a temporary device. It allows scar tissue to form, but many of the times that scar tissue will be enough to allow return to function. So we don't always have to reconstruct the collateral ligaments. And here we can see this is a frame that's been placed that allows access to the wound. So once we have our transarticular frame on, we can treat those wounds just like we would any other wound with regular dressing changes until we get a healthy granulation tissue bed. In this case, there was no injury to the digit, but you can see the metatarsal bone there. Generally speaking, that will still cover with very healthy granulation tissue. If you are concerned, you can drill little holes in that bone to allow vascular access. Generally, though, it's not necessary, and granulation tissue will form quickly, particularly if the periosteum is intact. And this is the case I showed you before. In this case here, we elected, rather than let that heal in through second intention, we elected to graft this to speed up that healing process. Now I'm going to show you another little case here. This is poor little Molly. Her identity is not quite been masked here. You can still see her. Here she is. And she's had a fall and sustained injury to the distal limb. We've palpated it, can feel instability, and now we can see no fractures, but damage to the ligaments here. So we've got metatarsal subluxations here. Now there are some cases where we just won't win and we just can't look to restore the normal functional anatomy. So in these cases, and actually in many injuries to the distal limb, our treatment may be for us to perform an arthrodesis. And so animals, particularly with pantarsal or pancarpal arthrodesis, can have excellent quality of life and excellent function. So we don't give up on these patients, but we accept when we're not able to maintain a healthy joint, an arthrodesis is important. And the key steps with arthrodesis is you need to remove all the articular cartilage, and that generally is with a high-speed burr, or you can actually use a saw and actually amputate the cartilage that way. but you need to remove all the articular cartilage. We then place in an autogenous cancellous bone graft and provide rigid stabilization, generally with internal fixation, such as this with a bone plate. Molly went on to run around quite normally. Sometimes we see fractures to the metabones. These are quite common. And I wanted to show you a couple of cases of how we might manage them. This little dog here is called Albert. He's had a previous radius ulnar fracture. He's an Italian greyhound, so it sort of comes with the territory. That was done about 3 years before he had another fall. What you can see, he has 3 fractured metabones. Now, this is where it's a little bit controversial. When do you do surgery on metabone fractures and when don't you? As a general rule, if I have more than 2 of those bones fractured, I will generally operate. Because what tends to happen is you get good stabilization of the metabone next to the intact bone, but the other 2 are very unstable. And so I will generally manage these with bone plates, and you can get bone plates small enough for an Italian greyhound. This is 1.5 plates, but you can also get 1 millimeter plates that are now available. So we treat them just like fractures anywhere else in the body. However, I never repair more than 2. And the reason for that is the soft tissue dissection that you perform around that is likely to be so severe that if you do all 4, you generally get a very swollen foot, and you may have vascular compromise to the foot itself, and you are at risk of losing the foot. So I select 2 digits to repair, and as you can see here, that digit that we didn't repair, that often goes on to heal just as fast as the others. You may have questions about cats to say, well, what do you do with cats? Well, in this technique, in this cat here, we can see 3 metabone fractures. So again, for me, I would generally recommend surgery. We can use a 1.5 millimeter plate. This is called an adaptation plate. It's not more than 40% of bone diameter, so I'm happy with that. And then I've used what's called a dowel pin. And so the dowel pin is actually where you've got just a small proximal fragment. You drive the pin in through the fracture till it seats distally. You cut off that pin, so about 1 centimeter is showing. Then what you can do is you can then realign the limb. So I do this as the first step. Traction, place it in through the proximal fragment and let it sit and hold in place. So it doesn't provide rotational stability, but I'm stabilizing the metabone next to it. So I do that step first, the dowel pinning. And then I look at plating the fracture next to it. And that plating of that fracture is much easier once you've stabilized it with a dowel pinning because it's not moving all the way around. So even in cats, it's possible to treat them in much the same way. And these animals will recover a lot more easily than having a big bandage or a cast on for anywhere up to sort of even 16 weeks for some metabone fractures. So I want to take you through a case example. This dog came in just around Christmas, I believe. And it's a 2-year-old French bulldog here. Now, generally, when you find out what the owners do, sometimes this causes you great stress if you're like me. You know, if I have dogs present that are owned by very powerful lawyers, I find this very stressful. This was not owned by a lawyer, but it was owned by a human trauma surgeon who is very familiar with treating these. And he was very concerned and he wanted to be very actively involved in this treatment process. So his poor dog was hit by a car. We can see we've got injuries to the back of that limb. We want to know what stage of healing we're in. We know that because the dog's just been presented. We want to know what extent of injuries have occurred. We cover it with a sterile dressing and we stabilise the patient. We call for Ellie. She's stabilised our patient. Now what do? Again, we want to assess the full extent of those injuries, first of all, and remembering debride, lavage, and the dressings. So we're going to start with that. So here we can see day 1. We're debriding all of the tissue that we know is obviously dead. Now what we can see here, and I'm sorry I haven't got the images, is what you can see is what's left of the olecranon. The triceps tendon has completely avulsed, and we've got now just the exposed olecranon. We're missing about 3/4 of the olecranon here. So that's of concern in terms of function. Here we are at day 3. Again, what we can see here down below, what you can see here, this is what's left of the triceps tendon, and this is what's left of the olecranon. You can see we've had further tissue necrose away in these areas here. And again, this is as we'd expect. At this point, remembering we're looking, is this moving from debridement to repair, or are we stuck in debridement? So day 4, we did the final change. This was, as I said, very close to Christmas, and here is the owner here, scrubbed in surgery with us. I spent 5 hours with him. We operated together. He was very keen to come in. And then I felt very guilty because he'd come in and he'd done so much work and I wasn't sure what to charge him. So we're in surgery and I said, oh, look, we'll work out something with the costs. And he stops and he touches my hand and he goes, don't worry, I'm not going to charge you for this. And I was like, oh, I was thinking that I would be charging you. But anyway, we came to a happy agreement. He was a lovely man and he actually did the graft. So we let him do that. And then he got us to do the hard part, which is the reattachment of the calcaneal tendon. So here we can see the graft, partial closure here. Now the graft's actually half failed. Now I didn't have the heart to tell him. I just said, oh, it's a partial take, but not that much survived. But anyway, we continued to bandage it, partial take, and this went on to heal very nicely. But it just, again, I wanted to highlight how we would approach these cases. Here we can see the end product. And we spoke yesterday about why we do what we do and how we can change people's lives. And these were videos that they sent to me over the following few months. So this was the first walk the dog took after we removed the bandages. And the owners were thrilled to see that the dog was able to use its leg again quite well. And then she sent me this video of the dog happily at home. And so again, I just wanted to emphasize all the hard work, all that effort. Doing the right thing is not always the easiest pathway forward, but the end result is really makes it all worthwhile. So this was my lecture on traumatic distal limb injury, and we've got a little bit of time. I know there's lots of questions, so I wanted to make sure we had plenty of time for questions. All right. Thank you very much. So actually, my final take-home messages, again, distal limb injuries are common, can be frightening. Assess that wound just like all our other wounds, daily dressing changes. And then once we've got granulation tissue support, then we can look at deciding to either graft or allow that to continue on to heal. And again, I want to thank you for your wonderful hospitality here. I'm having a wonderful time. And again, you can also ask me questions on Instagram. Thank you very much. Okay, so the question is, do I use collagen? In acute wounds, I use very little. I only use the body's natural tissues. And so again, there's often a temptation to use what's new and what's fancy. But often, if we use the principles of wound repair, often we don't have to purchase additional products. We know the body produces its own collagen, and if we support the fibroblasts, then again, they will produce not only huge amounts of collagen, but also a better quality of collagen than what you can buy off a shelf. So I don't use that in acute wounds. Yes, use of fish skin. Okay. So again, this is something that is new and used of humans. One of the challenges in human reconstruction is the morbidity associated with grafting, because we don't have a whole lot of free skin. If you look at our patients, particularly most dogs, you can almost take a handful of skin, and bring your hands together. So our patients generally have the luxury of lots of free skin through which we can graft. However, if we didn't have to do an extra step and it was cost effective and provided as good quality repair, then again, I would consider it. But whenever we're asking a wound to heal, remembering we need all these key elements. We need the scaffold, and that's what collagen and fish skin can provide. You need a scaffold. You need cells which produce new tissue, yes, and you need the growth factors. If you don't have all those elements there, then the wound healing process doesn't take place. So whenever you're thinking about why a wound isn't healing, you need to think about all those elements. And this is why chronic wounds are really hard, because the chronic or the older wounds don't have the growth factors. So you can bring in, potentially a nice scaffold, but unless there's healthy cells to produce new matrix, and unless there's growth factors to signal those cells to produce more matrix, then we won't get the result we're after.
Dr. Ten,
Yes.
Yeah.
Why don't we stand up when you ask a question? Then I'll find you easy. Yeah.
So, is it necessary to maintain negative pressure at the wound site after skin graft? And if so, how to maintain negative pressure at the skin graft?
So, question again?
Is it necessary to maintain negative pressure at the wound site after the skin graft? If so, how to maintain it?
Yeah. No, it's not. What we know is a negative pressure wound therapy creates a better percentage of take, but it's not essential. So using conventional bandages, we can still get very high percentages of graft take, but negative pressure wound therapy can improve the percentages. And the way you have to do that is you use essentially a thin film, and it's got a little tube that comes out of it, and you seal it all around the wound, and then you can place it to a suction device. And that suction device is what pulls everything out. You need a special foam as well. It's probably a whole other lecture on negative pressure wound therapy. I guess it was very popular some time ago, but because the animal has to stay in hospital, because it has to be connected to a suction tube constantly, I think it's gone a little out of favour because it is quite labour intensive. If anything lifts or comes undone, it doesn't work. So it's very labour intensive.
Excuse me, sir. Here.
Yes.
So can you just throw a light on ozone therapy on wound healing?
Okay, yeah. Ozone therapy, I have no clinical experience with it. But again, it's something which I think would be reserved for a certain subset of these wounds. Have you got experience with?
Yeah, we have ozone in house. So we were trying this wound healing. So where there is a major wounds, so we were using this. So this has some good effect. I don't know. I just wanted to ask your input so that it can be bettered.
Yeah, I think it's always tempting to look for anything that might improve the process, but there are actually very few proven techniques that speed up that healing process. Again, the way I think of it is as long as we don't slow it down, then we're in good shape. But the concern being that, again, often we don't have the evidence to support its use in every case. Because most of the time the body wants to heal on its own, you could do a number of things and probably you'll still see positive effects. So I'm not convinced that it's going to be a big part of wound healing in the future, but there are many modalities, particularly for chronic wounds, to re-stimulate that process. And I think that's where a lot of these newer modalities come into play.
And one more question.
Yes.
So we have some cases where all the phalanges are broken.
Yes.
So in that cases, which two phalanges you would choose to go for the fixing or stability?
Yeah, great question. It could generally, if it's all four, I would pick 3 and 4, the central two, because they're bigger and longer. But that's not 100% because sometimes metabone fractures might be very close to the joint. So those ones I try and avoid. I'll pick the 2, hopefully that are central. But if they're very close to the joint, then there's no hard rule about the central 2 being the ones you have to repair.
But major weight-bearing phalanges are 3 and 4. So
yeah, here's an interesting thing. I think we're challenging conventional wisdom. I think looking at the dog, all 4 bear weight. And they bear weight because the pads are in an arc like this. So the lateral 2 have to be shorter to contact the ground. So newer evidence is suggesting that all digits bear significant load. And if they didn't, you'd probably have a foot that looked more like a pig, where those 2 digits would come all the way up the limb. And so this is really interesting because, we know that those central 2 are not necessarily more important. All those are potentially important.
thank you.
And deep contaminated wound, the infection is very common.
Yes.
What type of combination of antibiotic you prefer?
Yes, okay. Antibiotics. Generally, I'll start with broad spectrum antibiotics. Normally, cefazolin would be my go-to initially. If I think there's fecal contamination or we might have anaerobes, then it might be amoxicillin clavulanate. But generally, I would start empirically with very simple antibiotics. So cefazolin or amoxicillin clavulanate acid are my 2 that I'll go to first of all. What I don't do is I don't take an exit culture. So I don't clean the wound and then take a culture. It doesn't hurt, but it costs the owner more money. And rarely what you culture on exit, whether it be a hip replacement or a wound, rarely is the organism that may be cultured on an exit culture responsible for the subsequent infection. And so what I'll generally do is just a culture if I'm seeing signs that an infection is occurring.
We found the piperacillin with metronidazole was helping in many cases. Piperacillin
Yes?
with the metronidazole. Metronidazole
Metronidazole?
And the piperacillin, no?
Yeah, so metronidazole could be useful, particularly if we're worried about anaerobes. Yes, but it depends where the wound is and what we're worried about will be the major contaminant.
Chris, this seed grafting.
Yes?
So what is the
Please note that this will be our last question as we really have to move forward towards the next segment. Yes, sir.
what is the preferred size of the diameter of the graft,
Yes.
and how do you tack them to the granulation tissue?
Yep, great. I take an 8mm graft because it's big, and so I take an 8mm graft. You've got two techniques in the graft bed. So you can either make a little slit and squeeze it in there, but sometimes they fall out. So often what I'll get is a 6mm graft, and I'll make a 6mm hole in the granulation tissue bed, and I'll put my 8mm graft. Often that shrinks down to about 6 or about 6.1 hopefully, and then you should be able to squeeze that in that little hole. So the 8mm skin fits in about a 6mm hole when you put it in.
So you just plug it, you don't stack it?
Don't tack it. No, just plug it in there and put a bandage on top. Don't change it for 5 days.